The genital ducts are naturally undifferentiated tubular structures. Both male and the female embryo have two pairs of genital ducts, mesonephric duct and paramesonephric duct. Mesonephric duct is also known as Wolfram duct. Paramesonephric duct is also known as Mullering duct, named as the scientist who first discovered this structure. As mesonephros degenerates during the end of the second month, mesonephric ducts and part of mesonephric tubules are reserved, participating in the formation of the male genital ducts. The paramesonephric ducts forms from a longitudinal invagination of the mesothelium on the surface of the urogenital ridge. The coelomic epithelium invaginates and forms the paramesonephric duct. Cranially, the duct opens into the abdominal cavity. The cranial end is funnel-shaped. It first runs laterally to the mesonephric duct, and then crosses it ventrally and continues to grow toward the median plane, and then fuse with each other. The caudal end of fused ducts is blunt and projects into the posterior wall of the urogenital sinus and produces an elevation or small swelling in the wall of the urogenital sinus. This is the sinus tubercle. Before the 6th week, the genital system is in an indifferentiated stage. Both pairs of genital ducts are present. During the 7th week, the genital ducts begin sexual differentiation. If the embryo is a male, under the influence of the testosterone produced by Leydig cells of the fetal testes, reserved mesonephric tubules form the afferent ductules of the testes. The mesonephric duct develops fully to become highly convoluted, forming the epididymis, different duct, seminal vesicles, and ejaculatory duct. Except for the testosterone produced by Leydig cells, Sertoli cells of the fetal testes can produce anti-Mullering hormone. Under the influence of the anti-Mullering hormone, paramesonephric ducts degenerate in the male. If the embryo is female, because of the absence of the testosterone, mesonephric ducts and tubules regress. Without the influence of the anti-Mullering hormone, paramesonephric duct develops fully to form the female genital ducts. The cranial and medial parts of the paramesonephric duct give rise to the oviduct. The caudal fused portion of the paramesonephric ducts gives rise to the uterus. The sinus tubercle gives rise to the vagina. One common anomaly of the sexual differentiation is testicular feminization syndrome. The patients have a 46XY chromosome constitute, but have the external appearance of the normal female. The testes are usually in the abdominal cavity or the inguinal canal. This disorder results from a lack of androgen receptor. The somatic cells don't respond to testosterone because of lack of androgen receptor, just as there is no androgen in the embryo body. Without the influence of the testosterone, mesonephric ducts and tubules degenerate. With the influence of the anti-Mullering hormone produced by Sertoli cells, paramesonephric ducts also degenerate. The external genitalia differentiate into the female external genitalia. It has been reported that medically, legally, and socially, these individuals are females. Once diagnosed as testicular feminization syndrome, the testes are usually removed as soon as possible because there is an increased risk of the tumor formation of undescended testes. Well, this is the development of the genital ducts and the clinical correlations. Pay attention to the difference between the male and the female. Now, share one case. A 17-year-old girl presents with a complaint of amenorrhea. Physical examination reveals good breast development and a normal amount of pubic hair, a rudimentary vagina, and the mobile mass within both the right and left labia majora are found on pelvic examination. Ultrasound reveals the absence of a uterus. What is the term given to this condition? Explain and the embryological origin of this defect. Thanks for listening.